My name is Dr. Barry Gidal from the University of Wisconsin School of Pharmacy, and welcome to this installment of Clinical Corner. And I'm really pleased to be joined today by colleagues Dr. Wesley Kerr from University of Pittsburgh, Dr. Cara McAnaney, also from the University of Pittsburgh, and Dr. Sean Avedissian from University of Nebraska. And our topic today is something that I think has perhaps been under-recognized within our epilepsy community, and that's the topic of PEP and PrEP for HIV, and what are the implications in our patients with epilepsy? So, Wesley, I'm going to turn to you first as the lead author on a paper in Epilepsy Currents. Why did you choose to look at this? What are the issues here?
So for treatment of HIV, which is where we have a lot of our data, especially in underprivileged areas, there's an idea that you choose to either treat the seizures or the HIV. That's no longer the case with newer HIV medicines, and it's no longer the case with newer anti-seizure medicines. So you can treat both effectively. And especially an underutilized treatment is pre-exposure prophylaxis, PrEP, and post-exposure prophylaxis for HIV. So we wanted to make a practical guide for people who treat seizures to understand what are the interactions between these PrEP and PEP and the seizure medicines so that we can effectively treat both of them.
Okay, thanks. So, Cara, I know you're an expert in this area and you spend a lot of your time working in this area. Tell us a little bit more about these treatment regimens and this whole notion of utilization.
Sure. So post-exposure prophylaxis and pre-exposure prophylaxis are using either full or partial HIV regimens in order to prevent the transmission of HIV. So for pre-exposure prophylaxis or PrEP, you're using a partially active regimen before any expected exposure to HIV, whether it's sexual, through injection drug use, or some other way, in order to prevent contracting HIV. And it's highly effective when it's used correctly. It's 99% effective in some cases, but it's really not used that much. So even though a lot of people can benefit from it, recent data from the CDC shows that only 36% of patients in the US who were thought to benefit from PrEP were actually prescribed it. Post-exposure prophylaxis is used after an exposure. So that's using a fully active 3-drug HIV regimen to prevent transmission after an exposure has occurred. It's time limited, so it's very important that people get access to it within 72 hours after the exposure. And really, the earlier the better. They have to start it within that time frame, but it's most effective in the first 24 hours. And it's a discrete course that only lasts about 28 days, so patients are on it for a very limited time. Because of this, it's really important that all providers are familiar with it, since people have that sort of short window they really need to know. But unfortunately, less than 25% of primary care providers in the US have said that they prescribe it. So it's another thing that we're really not using as much as we should.
As a follow-up, can I just ask you, is there any data specifically within population patients with epilepsy that is there more of a perceived stigma and they're not talking about it as much? Do we have that kind of data, or is that something we need to maybe explore more?
So we do know that there is some increased risk, probably among people who are on medication for epilepsy. We don't know specifically about their ability to access these medications, but I think that's why for epileptologists, it's really important for epileptologists to be aware of it and talk to their patients, because they'll be having contact with their patients on a regular basis, and other providers might not be.
So maybe something else we need to consider when, with all the quality measures that we have with patients with epilepsy and taking a good history. So I know we've talked about these antiviral agents, and they're complicated. Sean, I want to turn to you. Can you tell us a little bit about the pharmacokinetics, and what are the considerations we need to be thinking about?
Thanks, Barry. So that's a great question, and it's a very multifactorial answer. These HIV medications and these anti-epileptic medications, they have multiple interactions with both phase 1, phase 2 metabolite enzymes, UGT, cytokine P450 enzymes. And a lot of times these interactions are, may or may not affect the concentrations of the antiviral agent or vice versa of the antiepileptic medications in the blood. So we really need to make sure that these potential interactions are not causing any effect on the efficacy of the drug. There was a study back in 2020 that showed that serum levels of tenofovir diproxyl fumarate and tenofovir alafenamide fumarate were 50% reduced in patients that were co-treated with carbamazepine or oxycarbamazepine due to these potential PK interactions. However, I can say that just from the University of Nebraska Medical Center standpoint, that so even though we have patients that may be on these medications, we don't normally see any effect on outcomes or efficacy. But these are interactions that we do need to take into effect. Ideally, there is a great tool that University of Liverpool has published on their website, which we talk about in our paper, the University of Liverpool drug-drug interaction resource that kind of gives you some of these complex interactions and potential solutions if we do find these clinically.
Okay. So you bring up an important point. So do we or do we not have data showing, it's one thing to show the pharmacokinetic interaction, but a link to outcomes, or do we simply just not know for most of these drugs?
For a lot, we don't know, and we do have for some drugs, but again, it's not as clear as we would like.
Okay. Cara or Wes, either one of you. So from your perspective of looking at potential treatment failures clinically, have you seen anecdotal evidence or other evidence suggesting there might be failures?
So I haven't seen failures, and I'm going to highlight the success of PrEP and PEP in that the studies of that have shown very good efficacy, greater than 99%, which is what Cara just said. A lot of the studies of post-exposure prophylaxis don't have any failures in all of their patients, which is something we want to maintain because a new diagnosis of HIV is a long-term thing. And a lot of these are studied in people with chronic HIV to look at the interactions. And there is some data there saying increased failure rates in people on dual treatments, primarily with the inducers. And there's a big list of the inducers. So there's suggestions that we should consider these things and think about practical dosing changes when we know about these interactions, and we describe some of those practical dosing changes. One of the things that I would highlight, it's not just starting a medicine. One of the things that we discuss is at the end of post-exposure prophylaxis and lamotrigine, one of the agents lowers lamotrigine levels, which then increases when you stop that agent. And then we worry about side effects with increasing lamotrigine levels precipitously. So thinking about all of the phases of care of starting the treatment, ending the treatment, maintaining the treatment is important.
Okay, so that's an important point you make. We shouldn't be afraid of using these, and we shouldn't be dissuaded from using these therapies. We just need to be cognizant. So in addition to pharmacokinetic interactions, the other concern we would have is about overlapping adverse effects, and how does that either add or subtract, or with our patients with epilepsy. Can you comment on that?
Absolutely. A lot of the overlapping side effects are common things that we see in both conditions. With the inducers, we think a lot about osteopenia, osteoporosis, and one of the tenofovirs, TDF, also has implications in that realm. We also think about dizziness as a common side effect to all of our medicines, the HIV medicines and the seizure medicines. And then there's other particular considerations that you can look into more detail in the paper about patients with particular conditions or particular problems like weight gain, weight loss, that can be common across both of them.
Okay. Well, this has been a great discussion. Again, it's something we don't talk about a lot. We clearly don't utilize these therapies enough in our patients. We need to be adding this part of the history, and we just need to be concerned about some of the drug interactions and hopefully how to manage it. And your paper does give some good guidance for healthcare providers. This has been a great conversation today. I want to thank you for your time and sharing your expertise with our audience.